The following is a paid advertisement of St. Anthony Hospital Orthopedics. References to any specific product, services, or entity does not constitute an endorsement or recommendation by St. Anthony Hospital, Carroll Broadcasting, or its advertisers. The views expressed by the host or guests are their own, and their appearance on the program does not imply an endorsement of them or any entity they represent. Welcome to the St. Anthony Hospital Orthopedic Show with Dr. Richard Godding. Dr. Godding specializes in joint preservation, reconstruction, and replacement surgery, and brings over 25 years of orthopedic excellence to St. Anthony Hospital and to the Carroll area. For more information about Dr. Godding, his practice, or St. Anthony Orthopedics, go to santanthonyhospital.org or make an appointment by calling 712-794-5536.
Good Sunday morning, Iowa. It's Dr. Rick Godding. Thank you for choosing to involve me in your morning here. And this week, I thought, I don't really that often go into the hand and wrist. And there have been things that, kind of things that have come up in the office, and different people have asked me. And I thought, so what I'm going to try to do today is go over the common things that occur in the hand and wrist and talk about which ones we treat. When I say we, I mean my partner and I treat primarily, and then the ones that we would identify and then send out to a hand surgeon. So in orthopedic surgery, when you go through your training, you do hand surgery, you do trauma surgery, you do joint replacement, you do sports medicine, you do all these different things. And then you can do what I did, which was to specialize beyond that. I did shoulder and knee fellowship training after my residency, which doesn't mean that I only do shoulders and knees, obviously, but it's the foundation of my practice and always has been. But because I've never been at sort of like an academic center or a place where it really gets, some of the bigger groups around the state, and then some of the academic centers, you get to the point where the shoulder guy might just do shoulders and elbows and maybe hands, depending on his training or her training. So most orthopedic surgeons are not in a situation where all they do is one or two things. Now, there are some, and that's fine, but I would be considered a general orthopedic surgeon with a specialty focus, and my specialty focus would be shoulders and knees. So I do treat hands. A little bit of foot and ankle, mostly basically at this point, just ankle fractures. I don't really treat any kind of foot pain or anything like that. Just something that we just don't see a lot in the office. I think a lot of that stuff just goes to podiatrists. But we do treat hands. And again, so in the training, when you're done, technically, when you're done with orthopedic surgery training, you can do any of it. Like I could do spine surgery technically, like coming out of a residency. If you said, well, I had an adequate experience in spine surgery and I want to do spine surgery, might be a little tougher nowadays, but certainly historically you could do it. I don't know. I think you probably could. I think, there's an interesting thing because there's like the legality of it. Legally, you certainly could. Your malpractice insurance, and so I'm talking about specifically spine, okay? Like your malpractice insurance carrier might say, well, you haven't done a spine fellowship, we're not going to insure you. So you might run into those kind of roadblocks, especially with spine. The rest of it, though, joint replacement, sports medicine, shoulder, foot and ankle, a general orthopedic surgeon is going to do all that stuff. And even, some elbow stuff, fractures and things around the elbow. It's an interesting specialty because, I guess general surgery is kind of the same way. You come out of general surgery and you can do pretty well everything, not hearts, of course, not brains, but anything kind of in the belly. But then the more specialized stuff, then you have other areas of subspecialty. But anyway, that's kind of how it works in orthopedics. When you're finished, the idea is you're ready to go out and be a generalist in the community or receive extra training to do something that's much more subspecialty focused. So now that we've talked about the whole training situation, let's get back to the hand and wrist and what we do here at St. Anthony's, Dr. Dirks and I. We pretty well do the same things. I don't think there's anything that either one of us does that the other one doesn't do. And it's basically, again, it's the general stuff. So first, and just kind of probably the most common thing that we do is wrist fractures. And we do this in all ages. We do this in kids, and we do it in elderly people, and we do it in middle-aged people. And what you'll find is that it's very rare for a kid to need an actual open surgery on a wrist fracture. Sometimes you might put a pin in, and as the child gets older and older, and once you get sort of around what we call skeletal maturity, sometimes you do, sort of 10, 11, 12, 13, 14, and up into there. Occasionally you would need a plate fixation, but I can say I don't think I've certainly never put a plate on someone under maybe 15. They're just rare. Most of the time with a kid, the way wrist fractures work in kids is the younger they are, the better they do. And unless the fracture involves the growth plate, if the kid is under age 9, you can accept almost any kind of deformity with the fracture. In other words, you don't even have to line it up well. I mean, they will regrow, and as they regrow, they straighten out. Once you get past 9 or 10, then they have fewer years of regrowth, and you kind of got to get that closer. And that's sometimes when we'll put a pin and a cast and those kind of things. And then just only in the most likely reason for a kid in a younger adolescent or older childhood group, so it's sort of the 9 to 13 or 14, the most common reason that a kid at that age would need a plate placed on their wrist is if they had a fracture through a growth plate. And so the growth plates are at the end of bones, and that's where the length of the bone comes from. So the bone, as you grow, the bone end, it's called the epiphysis, grows lengthwise. And in middle-aged people, we are much, much more. So anything from, let's just say, for simplicity's sake of discussion, from 18 to about at least into the 50s, if not maybe 60, right in there. You really got to have them pretty close to perfect. So you end up putting a lot more plates because they're no longer able to regrow, right? So your adult bones are not growing. They can get thicker and thinner based on a lot of different factors, but they're not growing at the ends. You're not getting taller. Sorry. Once you're usually 18, 16 for boys and girls. So the people in the 18 to, let's say, 60-year age group with a wrist fracture, and when I say a wrist fracture, what I mean is the radius. So the wrist is a bunch of bones. It's a bunch of small bones, the scaphoid, the navicular, the cuneiform, and multiple other smaller named bones, the lunate, the capitate, the hamate. There's a lot of bones in there in the wrist. And then those bones are called the carpal bones, and the carpus means wrist. And so those closer to your forearm, the joint is your radius and your ulna. Mostly it's the radius. That's the bigger bone in the forearm. So the forearm bones are the radius and the ulna. And then you have the carpal bones. Again, like I said, the scaphoid, the lunate, the navicular, the triquetrum, the capitate, the hamate. These are the very small bones, and they form sort of an inverted Roman arc. And those are the carpal bones, and then they articulate or form a joint with what's called the metacarpal bones. The metacarpal bones are the longer bones in your hand. They're analogous to the same long bones in your feet. And if you feel like you're between your knuckles and your wrist, after the bend in your wrist up to your knuckles, those are your metacarpal bones. So when we say a wrist fracture, typically what we're talking about is a radius fracture or a radius and ulna fracture. We're not talking about those small bones. That's a whole different set of things that we can get into. So the wrist fractures in children are typically casted. If it's really bad, sometimes you put a pin in, and only in the very worst cases, and in an older kid, maybe older than 9 or 10, you might put a plate on. Nobody's putting a plate on a 4-year-old wrist. You just don't. As you get past 60, the need, and this is interesting, the need for your wrist to be perfect at the radius level, at the level of the bone, in the forearm bone, the radius that is joined to the small carpal bones in the wrist. Got to have that right when you're 30. Really should get it right when you're 50. In other words, when I say right, I mean that bone needs to be lined up as close to its normal anatomy after the fracture as you can. And the most common way we do that is with a plate and screws. And you can treat it in a cast, but oftentimes that's not really sufficient to hold it. And then if you're really going to treat a bad one in a cast, you have to put it in a 6 weeks in a long arm and 6 weeks in a short arm cast. Whereas if you put a metal plate on there and you're holding it exactly where it's supposed to be, you can put a splint on for 2 weeks and then get it moving. So we really lean towards putting a plate on the distal radius, it's called the end of the radius, in a wrist fracture for late adolescents, 18, I guess those are adults, adults 18 to, let's say, 60. Now, once you get over 60, and certainly over 65 or 70, the wrist tolerates a tremendous amount of deformity. And there are multiple studies. It's a test question on the boards every time I just took my board for recertification. So when you graduate from residency, 2 years later, you take your initial boards, and then 10 years after that, you retake it, and then 10 years after that, you retake it again. So I'm on my second 10th year retake. It'll be the last time I need to take it because maybe. I don't think I'll be practicing. Certainly won't be full-time in 10 years, I can tell you that. Anyway, I digress. But it's always a question, what do you do with a 65-year-old with a wrist fracture? And typically you treat it in a cast and you accept whatever deformity, because even if their wrist looks deformed, they function quite well and can do everything that they want and need to do. Now, that's not all 65-year-olds, but that's most. Well, why not just put a plate on it? Because a lot of 65-year-olds, the bone is so weak that if you put the plate on, those screws just cut right through, and then you end up with a bunch of screws inside the wrist joint, and that's not good. So that's our most common surgery on the wrist would probably be a wrist fracture in an 18 to a 60-year-old, and then sometimes a little bit older and sometimes a little bit younger, but the bulk of them in that age group. And that is the injury that we operate on there, and that is how we treat them. So I guess we'll just stick with fractures here. Carpal bone fractures, and that's the smaller ones in the wrist, the scaphoid, lunate, triquetrum, capitate hamate. All of these bones, they all have very particular architectures, and they all have very particular things. There's one in particular called the scaphoid, and that's right in what they call the anatomic snuff box. People used to put snuff there and snort it off their wrist, and that's why it's called the anatomic snuff box. But if you touch your wrist on your thumb side, and you can feel the most prominent bone there is your radius, and then if you go a little bit towards the thumb, but not quite to the thumb, and then bend your wrist all the way to the other side, your finger will be on the scaphoid. You probably won't even be able to touch it, but the point is that's where the scaphoid lives, and it has a very particular type of blood supply. And because of that, if the scaphoid fractures, if it is displaced at all, in other words, if it breaks and it's in two pieces or bent, you got to get it straight. And we send those to hand surgeons. That's a hand surgery job. But a lot of scaphoid fractures are just cracks. And so the bone didn't break all the way through. It's still dangerous. And we put those in casts, and that's something that we would do. So the scaphoid, if anything else, very, very rare to break one of the other bones in the wrist other than the scaphoid, just because of the architecture of how it works. But any of those other smaller bones that were to fracture, we would send that out to a hand surgeon. Next we'll go all the way out with a trauma. So the metacarpal fractures, we would fix metacarpal fractures. And metacarpals are those bones, again, if you just touch the back of your hand, you're touching your metacarpals. They go between the carpal bones, or the small bones in the wrist, and the phalanges, which are your finger bones. And those bones we would fix. If sometimes you put a pin in it, sometimes you put a plate on it, but that's something that we do without sending out to a hand surgeon. Typically, if there's 3 or 4 of them broken, we would go ahead and send that to a hand or a trauma surgeon. Phalanx fractures, so most of those don't need to be fixed. Those are the little bones, the finger bones, the thumb bones. If they do need to be fixed, usually we will take care of those. And again, those are, you're either going to put a pin in it or put a plate on it. And soft tissue injuries on the hand that require surgery, so a lot of them are your flexor tendons. So if you cut one of the tendons on your finger or in your palm with a knife or a blade of some sort, Those are very particular about how they're fixed and how they're treated and rehabilitation and all that stuff. So we would definitely, at least I would, I'm not 100% sure about Dr. Dirks, but I would definitely send a laceration of a flexor tendon out to a hand surgeon. And those are the ones that curl the fingers up. They ball up your fist. Those are the flexor tendons. The extensor tendons, that's much less common to have a cutting injury of those. Typically, I would probably send that out anyway. I'm not sure about Dr. Dirks. And then sometimes you'll get what's called a mallet finger, where you have a trauma to the tip of the finger and it bends the finger really quick and it pulls off a piece of bone. And usually we can treat that with a splint. If it doesn't get better, then we would send that off to the hand surgeon. So that's kind of the basics of trauma treatment in the wrist and hand that really, I wouldn't think that what we're offering here is much different to what most community-based orthopedic, generalist orthopedic surgeons are doing. Some people have had more of a hand experience or less of a hand experience with vis-a-vis trauma or some of the other things having to do with the hand and wrist. But those are I guess I just went over the injuries today, and it looks like we're rounding the corner on this episode. So I think what I'll do next week, if my producer will remind me, we're going to do the more elective stuff, the carpal tunnels, trigger fingers, and things like that next week. But I thought I could get through the hand in one episode, but it looks like I have run out of time. So I'm just going to go over it real quick again. From an injury perspective, what your general orthopedic surgeon and what we would offer here without sending off to a hand surgeon would be wrist fractures. And when we say wrist fractures, we basically mean the radius and or the ulna. A non-displaced scaphoid fracture. Scaphoid is sort of the key small bone in the wrist that has a blood supply that makes it dangerous when it is fractured. We would treat those non-operatively, but almost certainly not operate on those. Metacarpal fractures, those are the bones between the knuckle and the wrist that you can touch on the back of your hand. Those we would fix. Phalanx fractures, we likely would fix those. And then tendon injuries, most of the time we're going to send those out, especially if they're on the flexor side or the palm side of the hand. Those can be pretty dicey and can need some advanced techniques, not just surgically, but also in rehabilitation and therapists who are used to working with them and all that kind of stuff. So that's hand and wrist injuries. And next week, what I will do is I will follow this up with, what are the hand and wrist surgeries that we would do, the tendinitis, the carpal tunnels, trigger fingers, the arthritis of the hand and wrist and those kind of things, what we would treat and what we would send out and what those treatments are. So I hope you learned a little something. Hope it was enjoyable for you, and you have a blessed week, Iowa.
This has been the St. Anthony Hospital Orthopedic Show with Dr. Richard Godding. For more information about Dr. Godding, his practice, or St. Anthony Hospital Orthopedics, go to www.santanthonyhospital.org or make an appointment by calling 712-794-5536.